So my topic is personalized dual antiplatelet therapy, DAPT, commonly known as after acute coronary syndrome. Now, in 2023, ESC and also SEC guidelines recommended DAPT by default should be continued for a period of at least 12 months for ACS and at least for 6 months for stable CAD, followed by a lifelong aspirin monotherapy in patients at low bleeding risks. However, duration of the treatment is not sacrosanct because of many factors which I'll be discussing. A balancing act is a very, very important issue which should be maintained to not to have the complications more, especially in complex PCI situations with high ischemic risk and potential bleeding risk. Post-PCI DAPT to a decrease leads to a decrease in rates of ischemic events at the expense of bleeding risk, and about 2 to 21% patients of ACS have atrial fibrillation. That is another facet which is added to the ACS itself. This specific cohort may require DAPT plus DPI. DPI means dual pathway inhibitor. The guidelines are different for this group. There is increasing role of DPI in complex PCI, especially in CAD, with or without PAD, and this has come after the various trials have come out. Now, this is the balancing act, and there are different facets of long-term risk factors for stent thrombosis after PCI, and also long-term risk for bleeding. And these are commonly known to all of us, but what should be the duration? What should be the particular agent we should use, and how should we use, and when should we use? These are some of the questions we'll have to answer. Now, as I told in the very beginning that the standard therapy is for 12 months, there are other options also in other conditions or specific conditions like shorter DAPT. It may be for 1 month, it may be for 3 months, and it may be for 6 months. And prolonged DAPT is at times warranted. More than 12 months, maybe it is continued up to 36 months. There are again specialist condition where we'll have to adopt that process, and that's why we need to call for individualized medicine. Now, there is a story of evolution of 12 months of DAPT after ACS, why it became the standard mode of therapy, and over a period of time, the recommendations changed from class 2AC to presently in 2023, it is class 1A in acute coronary syndrome. So these are long stories. To cut it short, the ACS incidence in atrial fibrillation in ACS patients is another facet. Almost 2 to 21% patients are there. And this actually needs, this patient of atrial fibrillation needs oral anticoagulation like DPI, as I told. And on the top of that, if you require the PCI, automatically there will be high bleeding risk. Now, how you are going to deal that, we'll be dealing with that. I'm going to some of the slides where the specific strategy is taken up without the OAC or with ASC. The first one is ACS without OAC. What is the default strategy? The default strategy is that aspirin is the class 1 indication, prasugrel or ticagrelor is the second addition, and if not available, then you should consider clopidogrel. Again, this is a class 1 indication. And this should be continued for 12 months, and that is again class 1 indication. Now, post-ACS SAPT strategy after 12 months is considered, and here by recommendation, aspirin is the class 1 drug. Now, you can think about other antiplatelet agent like P2Y12 inhibitor as a class 2BA indication. Now, without OSC default strategy again, you are to consider the same phenomenon up to 12 months. After 12 months, the differences come. If there is high ischemic risk, no high bleeding risk, then aspirin plus P2Y12 inhibitor is a class 2A indication. But if you think that there is moderate ischemia with no high bleeding risk, then you can think about aspirin plus P2Y12, but that is not a must that you will be continuing after 12 months. Now, what happens with the OSC strategy? Patient is having OSC, whether it is due to atrial fibrillation or due to some other conditions like high thrombotic state or patient with DVT and all this. So these are the cases where OSC is considered, and there, in case of PCI, the default strategy is that aspirin plus prasugrel or ticagrelor, and in their non-availability, clopidogrel, should be continued for at least up to 6 months. Maybe it should be considered up to 1 month, and then it can be considered up to 6 months. Now, after 1 month, preferably as a default strategy, SAPT is to be considered, and that is class 2 indication. Now, what is this preferable SAPT? The preferable SAPT is P2Y12 inhibitor, and after the 12 months, that is in case of this default strategy, then you are to continue with the OSC. So that is again a default strategy for patients who are on OSC. Now, there can be some modification in some very high risk patients where after 12 months, if you are to consider that the OSC is being continued, in that case there is a very high ischemic probability and no high bleeding risk, then you can consider as a class 2A recommendation with the P2Y12 inhibitor. Now, with moderate ischemic risk, you can think about it. You may not think. You can think about P2Y12 inhibitor. Same way in post-CABG patients after 12 months also you should consider the long DAPT. Same is the indication recommendation by ACC, SKY, and also other guidelines. In very high ischemic risk with low bleeding risk, DAPT should be considered. This is the summary slide to how to decide upon the various duration of the antiplatelet agents, whether it is stable or NSTEMI or ST, SES, and that is to be continued as per the recommendation. Now, there are few specific terms which are used for stratifying the changes in high bleeding risk patients, and this could be either de-escalation, and number 2 is the early cessation. De-escalation of DAPT intensity is defined as downgrading from the potent P2Y12 inhibitor to either clopidogrel or half dose of prasugrel or ticagrelor. And the early cessation means you are stopping the aspirin after 3 months and continue with P2Y12 inhibitor, or stop P2Y12 inhibitor after 6 months and continue only aspirin. So these are the two terms which are very much used, and most of us are using this, de-escalation or early cessation. Similarly, this meta-analysis is showing that in patients with acute coronary syndrome, unguided de-escalation was associated with the lowest risk of major adverse cardiovascular events and major or minor bleeding outcomes, while short DAPT followed by P2Y12 inhibitor was associated with the lowest risk of major bleeding and all-cause death compared with the standard DAPT. In high bleeding risk patients, short DAPT for less than 3 months followed by P2Y12 inhibitor monotherapy is preferred. Now, DAPT strategy in patients with ACS undergoing PCI, this is the algorithm. and stop DAPT or cessation is guided by different trials that has been shown on the left side, excellent, optimize, ISR, stop DAPT and all. And de-escalation strategies were guided by some of the trials like Antiplatelet, Telos, Hope, Taylor. This is a long list. I'm not going into the detail of it, but whatever I have said, that in the high bleeding risk, or which can be having the high ischemic risk and not at high ischemic risk, then DAPT strategies is like what has been shown on the left side, and not the patient is not at high bleeding risk but at high ischemic risk, and not at high ischemic risk, then the standard follow up with the DAPT, and standard duration should be followed up. And this is to summarize the tailored antiplatelet strategies in the contemporary DES era. There have been a lot of changes because of the advancement of the stent scaffold, then the stents, drugs that have been eluted on the particular stent, and based on this, the complications of the PCI or risk of the PCI, you can classify them into a high risk, ischemic risk with low bleeding risk, or high ischemic risk with high bleeding risk, or low ischemic risk with low bleeding risk, and low ischemic risk with high bleeding risk. These are based on the different patterns, as I have already alluded to. And if there is high ischemic risk with high bleeding risk, which is a very, very common condition, but at the same time very dangerous condition, then you should prolong the DAPT therapy, and after that, of course, the single therapy or monotherapy should be considered. Now, this is a very important slide. I think our colleague from Indonesia will confirm this, that there is a very high bleeding risk in case of the Eastern Asian people as compared to the other parts of Asia. And that is why this is called East Asian paradox. And because of this, actually, you ought to either de-escalate the dose or shorten the therapy of with the DAPT. And this is a very, very important medicine. And there comes the role of precision medicine, which is based on big data, then machine learning data, then the deep learning and AI, which will guide us to a much more better way to formulate what is the strategy we'll be taking care, apart from other factors like clinical variable, platelet functioning test, genetic testing, and all these will be taken into account, no doubt. In fact, all of you are taking those into account, but personalized care or care based on AI is a different ball game. And this is one of the ways the DNA sequencing is being done, and individualizing the patient of ischemic risk, and where should we use the higher kind of antiplatelet agents, the P2Y12 inhibitor. And also you can qualify the YP2C19 genotype, and thereby you can see whether there is higher aggressibility of the platelets or not, and based on that you can determine the dose and duration of the antiplatelet agent, and also you can de-escalate or cease the treatment therapy. Now, there are limitations. There are limitations of predicting the score with our standard concept that is based on the logistic mechanism. As you can see that we are always thinking in terms of statistics, and those are called logistic regression. And these linear regression may not be able to pick up some of the very, very important points, which will be picked up by some of the AI machines, and thereby this machine learning is data driven rather than hypothesis driven, and analyze vast amount of data, uncover hidden patterns, overcome non-linear and time dependent influences, and generate prediction tools. Same way, machine learning versus logistic regression model to predict outcome after PCI, they have shown very salutary result at the present point of time. This is one model which has shown the cross classification of MI and major bleeding risk with the help of machine learning, and that has been differentiated with the hypothetical trade-off between two types of risk, and they are also showing encouraging results. This is one slide to show the dynamic prediction of the ischemic versus the bleeding risk, and it will show automatically that you should take care of the bleeding or take care of the high risk, and that's how you should guide your treatment. There are challenges of AI and machine learning algorithms, like clear intended use is there, good quality data, adequate data size is very, very important, adequate representation of different cohorts based on age group, sex, ethnicities. As I have said, that Eastern Asian paradox is there, openness of data and software, and it must be validated. Proper approval by legal and regulatory bodies, conformity assessment procedure prior to approval is very, very essential, adequate data size, proper definitions for legal and methodological factors, and last but not the least, accountability is very, very important. Mind it, it is the machine which will be taking over the human intelligence, AI versus human intelligence, and we should not falter and we should not do the things on the wrong side, and that's why we'll have to have clean data and clear accountability. This is the proposed algorithm based on this personalized care of APT, more or less same, only some of the parameters that have been incorporated, like genetic testing, predicting the score automatically, and also the platelet aggregability, and all these are put in the ML, and they will guide you how to do the switching or how to do the de-escalation, how to seize the or stop the medications. So, ladies and gentlemen, this is my take-home message to all of you. There are advantages like variable interactions, changing impacts of time, and non-linear effects make AI and ML a promising tool for improved risk prediction and guidance for DAPT mode or duration after acute coronary syndrome. Challenges remain with AI or ML, and more validation will purify the status. More validation will purify the status. It should be validated and revalidated. No randomized comparison on DAPT modulation strategy is yet available. Personalized care and choice of antiplatelet agent and duration will be mostly guided by clinical considerations and various risk scoring system specifying ischemia or bleeding risk, as I have shown you in the algorithm. Guidelines. I would emphasize on this guidelines of our balanced approach with data available. You cannot go away from here to there. The guidelines, they have been well thought, and that's why we must follow the guidelines as much as possible. Thank you all for patient hearing.